Dr. Ramirez is not just my doctor. I'm not just a patient to him. He treats you like family.
Keeping that small town feel while maintaining access to an academic medicine and care. We share all the work being done to eliminate obstacles in healthcare in smaller communities. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Wide open fields, a strong sense of community, and peace and quiet, all things that attract people to smaller communities. And there can also be some obstacles. Sometimes patients living in smaller areas have to drive for hours for specialized care. But thanks to the Care Collaborative, for Glen Virden, the care came to him. When Glen Virden went to have his hernia repaired at Clara Barton Hospital in central Kansas, he wasn't expecting to hear this from a nurse.
She said, "How long have you had AFib?"
Atrial fibrillation, when the heart's upper chambers beat out of sync with the lower chambers. Glen's care team at Clara Barton said they could refer him to the University of Kansas Health System's electrophysiologist, Dr. Rigoberto Ramirez, to treat it. And instead of driving 4 hours to meet Dr. Ramirez in Kansas City, Dr. Ramirez would see Glen in Great Bend, just a 15-minute drive away from his home.
Someone that specializes in that. You don't see that a lot in the rural areas. It said a lot for me that someone would do that to provide that care out here.
The referral to Dr. Ramirez was possible because Glen's health team at Clara Barton is part of the University of Kansas Health System's Care Collaborative, an organization dedicated to delivering the benefits of academic medicine and access to specialists in smaller communities.
To see them come in to these areas and treat people like they're used to treating each other, it just makes you feel much more at ease.
Among the benefits of the Care Collaborative, working with individual physicians and other medical staff in smaller communities to share treatments available, as well as easy access for referring patients needing a higher level of care. And speaking of care,
immediately in seeing him and talking to him for just a few minutes, I noticed this is a guy that cares. In the rural areas of the state, that's the way people treat people. It doesn't matter if you live 3 or 4 miles apart, you're a neighbor.
Glen says Dr. Ramirez had that familiar demeanor and way of communicating that gave him a level of comfort that he simply didn't expect to get from a big city doctor.
I mean, out here in the rural areas, you know, farmers meet each other on a township road somewhere and they stop in the middle of the road and shut their vehicles off and roll down their windows and talk. That's what you get from them when they come out here as a doctor-patient relationship.
Glen would eventually need to travel to Kansas City one time so Dr. Ramirez could perform an ablation. But to be able to have all his other appointments and the follow-up care so close to home has been nothing short of incredible.
I have 2 simple words: thank you.
Our conversation today is all about access to care in smaller towns. And Glen and his wife Lisa are joining us from home today virtually, saving themselves a long drive to Kansas City. Now, Glen and Lisa, you recently moved a little bit closer, but you're still a couple hours away.
Correct. We recently moved to Andover area.
Congratulations on the move. And also joining us virtually is Dr. Rigoberto Ramirez. Dr. Ramirez is Glen's electrophysiologist and cardiologist, and Jody Schmidt. Jody Schmidt is the executive director of the Care Collaborative. So Jody, I want to start with you. Let's get some background for people who aren't familiar with the Care Collaborative. What is it?
The Care Collaborative is a program designed to bring the benefits of academic medicine, the same protocols that we use here at the University of Kansas Health System, help fit them for a rural environment, working with Dr. Robert Mosier, who's our medical director, who was a rural physician for 22 years, making sure that they fit a rural environment and then bringing it to the rural community through boot camps, through electronic protocols, through training programs, through the support of our team, with the goal of local physicians having all of the access that our academic physicians do here to the very latest research, to the latest recommendations. We started out in Northwest Kansas with 13 rural members, and we now have 85 members in 73 Kansas counties, all working together to improve and bring the highest level of quality care to rural communities.
When this organization began with just the 13 communities, it began as a heart and stroke initiative. So how did this collaborative help in those areas specifically?
Yes, we started out as the Kansas Heart and Stroke Collaborative, and when we looked at the data, we found that timeliness of heart care in rural communities in Kansas was deeply concerning. We weren't meeting the same sort of standards of timeliness that you would see in an urban area. And so we really worked to bring the best practices to the rural communities in terms of getting started right away with that diagnosis, getting started right away with imaging, and moving forward, not waiting until they could reach an urban cardiologist before they started those processes. So we could really address the timeliness that's so important from a heart care perspective. Similarly with stroke, and also increasing the use of thrombolytics for stroke patients, for patients too far from a cardiac cath lab, for example, providing guidance and support to treat them with lytics as well. We then added sepsis and heart failure, and our most recent program is around diabetes. So from a heart perspective, it all started there, and we just celebrated our 10th anniversary.
Congratulations on the big anniversary. Jody, can you explain quickly to our audience the kinds of services that a patient might notice or that a doctor would enjoy through the Care Collaborative?
Sure, absolutely. It all starts with understanding the care that's happening already in a rural community and bringing what we call our boot camps to the rural community so that we can talk about the very latest research, the very latest evidence, and have conversations around what are the barriers to that care in that rural community, and then providing care management protocols that can be customized to the resources that are available in a rural community to make sure it fits for them, but also talking about where are the next closest resources and what are their telehealth options, and do they have the right medications in their local hospital pharmacy to address the very most recent recommendations around care. So it all starts with an understanding of where they are and what best practice says should be the way a patient is treated, no matter whether they present to a rural emergency room or to our own emergency room here in Kansas City.
Dr. Ramirez, I'm going to get to you in a second, but first I want to go to Glen and Lisa because they talk about you in such glowing terms. Glen, the first time you met Dr. Ramirez, you said, "This is a guy that cares." Were you surprised at that connection that you felt?
Yeah, I really was. I don't know what my expectations were, but again, being in rural Kansas and a doctor coming from Kansas City, I guess my mind tried to tell me that this is a guy that's not going to have much time, got to get in, got to get out, make time count. But as soon as Dr. Ramirez walked in and sat down, I mean, we didn't talk about, you may be used to hearing someone say, "So tell me a little bit," and they mean medically, what's going on? Give me some past medical history. Dr. Ramirez and I didn't do that at all. We talked high school sports. We talked, I took the opportunity to talk about our 6 grandkids. We talked about just family things. I asked him about his family, and just that time together, I was sitting there thinking, this is a guy that cares about me. And that meant a lot to me.
Dr. Ramirez, what a wonderful compliment. Is that the kind of time that you knew? Are you able to judge your patients right when you see them and think, okay, I can form a personal connection with this guy? Could you sense maybe that Glen was a little nervous?
You can sense some of those things. I don't know. It's hard to see Glen nervous. I think he does a good job of not being nervous with these interactions. But I think the important thing is just knowing. So, just a little background. I am from Great Bend, Kansas, and so, I'm from the area. And so for me, being from the area just really makes a big difference because that community is extremely important to me. And, when I don't treat anyone differently, but when I go in, I try to form a personal, relationship with each one of, each one of my patients, so that they feel comfortable and they're able to share, share their concerns with me and be open with them. And once you build that trust and they feel that confidence to be able to share that, I think our patient, the patient-physician relationship, it's taken off to a different level. So it's very naturally to go into Great Bend and, this is my community, these are my people, and these. I think I'm glad that I'm able to sit there and talk to Glen about, kind of things that, locally, those stories that I had back, when I lived in the area, and all of those are direct connections to him and to what we can, those are the things we share that really make us human beings, right? So to me, that's important. That's step number one. Then after that, we start talking about, what we need to do to address, the concerns that he came in to see me. But you establish that relationship up front, your relationship will always be, improved and much better moving forward.
Lisa, you and your husband are best friends. I know that from speaking with you and knowing you over several months. So I also know you were really worried about him. Yet you were able to trade in a 4-hour drive to Kansas City for just a 15-minute drive to Great Bend for his fantastic care. How much of a relief was that as Glen's wife?
It was just a big relief, knowing that you don't have to travel, a long journey and it's short, and it just took a lot of the pressure off.
Dr. Ramirez, how often are you seeing Great Bend patients?
So I am in Great Bend once a month. It's usually the second, Friday of every month. And so I typically see about 15 to 17 patients. And here, most recently, we're also doing some procedures, which, Glen was, Glen actually received one of the small little implantable devices that we put in to monitor for AFib. But typically once a month, and we're, looking as the clinics become more full, we're always reevaluating whether I should be out there a little bit more to provide more of that support the community needs.
It's something that you're passionate about, professionally and personally.
Extremely passionate about this. I think that growing up in a rural community and just understanding the obstacles that that community has to in access to care is extremely important. It's extremely important for me to try to overcome those. And this is the thing, is that when I come from Kansas City to Great Bend, that level of care is exactly the same as it is in Kansas City. So what I provide in Kansas City, and the access to the specialty, doctors, the heart failure doctors, the interventional doctors here, all of that I bring to Great Bend is directly accessible to patients. It's just closer to home. And so they get that direct access to me, but it opens up basically a world of specialties and a world into our KU system that really I feel strongly and very passionate about is one of the best systems definitely in the entire state, probably nationwide, in terms of treating any condition.
We know that primary care physicians are crucial in that day-to-day care. What services do you provide as an electrophysiologist for patients like Glen, who has AFib, that might be difficult for him to access living where he was living at the time?
So from a heart and rhythm perspective, so the electrophysiologist is essentially the heart and rhythm specialist. So when I'm in Great Bend, I have two hats. I am a heart and rhythm doctor, but I'm also a cardiologist, correct? And so what happens is a lot of the primary care physicians refer patients to me for both. Probably 30% of the population that's referred to me is general cardiology, and the other 70% is, heart and rhythm disorders. And essentially the one thing that's just amazing about these rural communities is that these primary care doctors know how to take care of patients. They are so good at this, and they extend. They're basically they're generalist, and they are very good generalists. So they're able to take care of the basic, cardiovascular, health maintenance issues that they need to take care of and stay up to date with that. And so when they come in and see me, patients come in and they've been very well cared for. They're on the right medications, and essentially I'm able to sit there as their cardiologist, review everything, and add just that additional medication that they need to optimize their care, or then, be able to, do what I love, and treat the heart and rhythm disorders that they have. As a heart and rhythm doctor, we treat several different conditions. Of those conditions that are the most prevalent are atrial fibrillation. The other ones are ventricular tachycardia. And we also are, the ones who implant the pacemakers, defibrillators, and treat these slow heart rates that are quite symptomatic. These interventions can be life-changing for patients, and and so those are my main focuses when I'm in Great Bend.
I've heard electrophysiologists describe what they do. When I say, tell me in lay terms, they say, well, we're like electricians for the heart. Is that kind of what it's like?
So in cardiology, there's this, everyone wants to be a part of a house, right? So the heart failure team is the house itself. So they'll tell you that without the house, you don't have anything else, right? The interventional doctors are the plumbers, so they go in and they open up the vessels so that the blood flows well. And basically, we're the electricians, right? So we take care of the electrical system to keep the lights on so you can come home to a lighted house, right?
Right. No one wants to come home to the dark. We already have some questions that are coming in. If you have a question as you watch our discussion this morning, or a comment, you can send it to us in real time on YouTube, Facebook, or the All Things Heart email. You will find all the links on how you can connect with us right now on your screen. Glenn, I want to ask you about your heart. How is your heart health today?
Alexis, my situation might have been a little bit different for the fact that I didn't even know I had AFib. I'd never had any problems whatsoever going in for the pre-op for the hernia operation when the radiologist said, so how long have you had AFib? Of course, I felt that was a joke, so I kind of laughed. And shortly after that, things got serious. I found out that it wasn't a joke. And then seeing Dr. Ramirez and having that time, again, him taking the time to explain to me, Dr. Ramirez, what is AFib? What can this do? What should I do? Just that time to explain it to me. So I had this extreme nervousness because I don't know. And he gave me the sense of knowledge that relieved me a little bit. But then after the procedure and getting it done and the loop recorder put in that I have now, my worries are gone. They truly are. I feel great. I'm not having any problems with my heart at all. As far as I know, I've never gone into rhythm again. Everything's been great. It's been steady. But what he gave me was that, again, that sense of everything's okay. And if it's not okay, we're going to know about it because you got a little deal here that's going to tell us that something's going on. So right. I rest easy at night.
He gave you peace of mind, which is Absolutely. Such a gift. You only had to make the drive with Lisa one time to Kansas City for the ablation. What was that process like?
It was good for one. Anytime we get to go somewhere, that's good. But, I can't say enough about the staff at the hospital. From checking in to leaving and getting in the vehicle to come home. The whole experience was absolutely wonderful. I got the same experience with the staff in Kansas City at the hospital that I had with Dr. Ramirez in Great Bend. Mm-hmm. That every one of them, I hate to say it cliche-ish like that, but it was all about me. And they made me feel that way and wanted to make sure that I was taken care of. And I was confident the whole time. Now, am I going to sit here and tell you that I wasn't nervous? No, there's no way that I could. This is the first time I've had something major like that. It scared me. It scared me a lot that Dr. Ramirez was going to go up in my heart. That, I was terrified. But obviously having Lisa there with me took a lot of that away. As long as she's there, I know I'm good. I prayed about it, and I said, it's in Dr. Ramirez's hands, Lord. Please don't let him sneeze.
Now, you and Lisa, are you junior high sweethearts or high school sweethearts? You met very young, right?
Middle school, junior high.
We started dating at 13. We got married at 18.
Oh my gosh. And Glenn, you've said you were from the wrong side of the tracks, and that's what drew Lisa to you.
We, growing up, were probably, I would say, the most polar opposites you could find. I use that analogy. I grew up south of the tracks. She grew up north of the tracks. How and why the good Lord put us together, I think that again is just to show that God's got a sense of humor, because he said, watch this, I'm going to put these two together.
Oh, you just described a great love story. So Lisa, your husband's sitting next to you, and I asked him how his ablation went, and he says, anytime I get to take a trip, it's a good time. Was it a good time for you, or were you sitting there in the car worried sick?
I was worried. We are a Christian couple, and I totally gave it to God that, yes, I was human. I was nervous. But I just kept praying, of course. But when we got there, the nurses did, inform me, and everyone was so polite and helpful, and that really eased my nervousness somewhat, yes.
Dr. Ramirez, can you explain to us, non-medical people, what happens during an ablation? What are you doing?
Of course. And so, Glenn, thanks for all those words, and I think it's basic, that's always really encouraging to hear. And, because that's exactly what we want to do. We want to translate what we have here in Kansas City over to any place we touch, right? And so, but here as you kind of look at this video, so basically an ablation procedure is a procedure that is done via catheters, okay? So this is done via catheters in the major vessels in the legs. We put catheters up from those vessels up into the heart. And as you can see here, the heart. Essentially, this is a complicated kind of image here where you see kind of the heart with a lot of leads. They have a device, a pacemaker, a defibrillator. But what we do with these is these catheters go inside the heart. They monitor the heart. They basically get all the electrical signals. They're able to show us patterns of how the electrical signals within the heart go and essentially tell us how healthy those electrical signals look. And when we put these catheters up, typically there's one catheter that will be able to provide interventions, and that intervention is called an ablation, okay? That ablation can be several forms. It can be heat or cautery that's applied to the tissues to basically cauterize or burn tissues that are malfunctioning or not acting the way they should. And or it can be kind of a freezing technology, and or most recently it's these electrical pulsations that can essentially deactivate parts of the heart muscle that aren't acting correctly, okay? And so what we do with these AFib ablation procedures is we know from research going back almost 20 years now or longer that the main trigger for the atrial fibrillation comes from these veins that are delivering blood from the lungs into the left upper chamber of the heart. And so for what I did for Glenn was we put catheters up, we crossed over from the right upper chamber of the heart over to the left upper chamber of the heart where these veins dump into that left upper chamber. And essentially what I did is I ablated around the opening of those veins, and what it does is it traps those triggers in the veins, and those triggers can no longer come out, irritate the top chamber of the heart, and put him into AFib. That's the simplified version. There's a lot of technology that goes through this, as you saw kind of through the video. When I put these catheters up, that's, step number one. Once I put the catheters fires up, I, essentially cross from the right to the left, and then I create a shell using very sophisticated technology. I create a shell that gives me the anatomy of that chamber of the heart, and it will help me determine where I'm going to deliver each one of these lesions. And of course, we're doing all of this in a beating heart that's very closely monitored, throughout the entire time under general anesthesia, and also monitored very closely by our technicians to make sure that all the rhythms are stable and everything else remains stable. The procedure typically, most of our electrophysiology procedures can take anywhere from an hour and a half to up to 4 hours, and this AFib ablation procedure typically takes about 3 hours in duration, 3.5 hours. And, typically it's an inpatient, the patients come in, we have the procedure done, and essentially they stay with us overnight, and the next day they go home.
So the next time, Glenn and Lisa, were you back home? The next day?
Actually, we came in one day, we had some testing, pre-op testing. The next morning, the procedure was done, and we spent the night, like Dr. Ramirez said, and then we went home the next day.
Jody, I have a friend whose dad was a doctor in a very small town in Kansas, and he was beloved growing up. She said their home phone would ring, and he'd do everything from treating strep throat to having to go deliver a baby. What kinds of extra tools would the Care Collaborative have given someone like that doctor, her dad, decades ago?
Yeah, our primary care physicians in the rural area, as you said, take care of everything that walks through the door, and they may be providing care, in the grocery store, running into somebody at a ball game, as well as the more traditional sites. They're covering the emergency room, their rural practice. Many times they're the medical director for EMS and for public health, and they go to long-term care. They just do amazing work. I've seen so much in my 35 years working in rural healthcare that makes me really proud of the tremendous physicians and nurses and all the team that provide that support. Our goal is just to make things a little easier, to stay on top of the research and bring it to them so they don't have to go out and find it themselves, to bring the training to their rural community. So not only are we bringing the latest research to the physicians, but the nurse practitioners and the physician assistants and the nurses in the hospital, the EMS crew, so they're all on the same page. And we also work with the regional cardiologists to make sure they're on the same page. So our goal is really just to say, let's all be working from the same playbook, and let's all just make it as easy as possible to adopt, because we're going to bring the tools to you. You don't have to start from scratch to develop them. You as a physician don't have to train your local nurses around the protocols, etc. You can customize it any way that makes sense for your community, but we give you a leg up by starting that process and bringing as many resources as possible to that rural community.
We are getting so many questions and nice comments, so I want to start with a comment from Reagan. Dr. Ramirez, this one's for you. Reagan writes, "Thank you for your continued service to Great Bend community. Dr. Ramirez, we are so fortunate to have you here." A lot of love going on. Jill has a question. Jill wants to know, we always talk about preventative heart disease. Was what Glenn suffered preventative, or was it hereditary, or was it bad luck?
Yeah, that's a great question. So, with everything from a cardiovascular perspective, there's always a prevention aspect to this, but I think, there's times when it's just genetics, right? So if you look at, in Glenn's situation, for example, he exercises, he's active, he takes care of himself, he's got given his occupation and his job, that's kind of part of all of that. And, but there are, certainly risk factors that you can look at and that you can control to help prevent, the atrial fibrillation episodes. So it's estimated that 15% of the population over the age of 70 will develop AFib, whether they have, comorbidities or not. Okay. And then the other population that develops AFib, it's usually associated with the same risk factors that cause coronary artery disease. So obesity, inactivity, high blood pressures, diabetes, and and high cholesterol. And those individuals, if you control those, if you have those, you're already at a higher risk of developing AFib. If you control those, you reduce your risk of developing the arrhythmia.
Rob has a comment. Rob writes, great program, very informative. Thank you, Rob. And Jeremy wants to know, this is a great question, how does it work with insurance? Since the care or the doctors or services aren't typically local to the rural communities, is this part smooth? Jody, you want to take that one, or
Jody,
Dr. Ramirez?
Go ahead. We have not typically found tremendous insurance issues within the state of Kansas, which is where our Care Collaborative works, and with the health system being the academic medical center for the state of Kansas, we are generally included in most individuals' insurance plans. We do have a team that does a really great job of making certain that you have the right coverage for those patients that do need to come to us for the care that we provide. Dr. Ramirez, what else might you add?
Yeah, no, Jody, I'm with you there. I think the good thing about all of this is that we're in Kansas, so, the University of Kansas is a state institution, and essentially, we are here to serve, anywhere from the, western borders of Kansas to the eastern borders of Kansas alike. And so I think that, for the most part, I have not seen, we've done several interventions, several patients that have had to come to Kansas City, or we've taken care of in Great Bend, but I've not had a single issue where I've had to fight insurance to be able to get us, kind of these, these interventions, or to be able to do what I need to do for my patients in Great Bend.
Boy, that's reassuring, because insurance stresses everybody out. As we wrap up this conversation, I want to get some final thoughts from all of our guests. Glen, I want to start with you. What message would you have for Dr. Ramirez and for people watching this show right now?
Once again, I've said it before, I'll say it again. Can't wait to see you in person again, Dr. Ramirez. Believe it or not, I kind of like you. So the best thing that I can say to you and your staff is thank you. Thank you for what you did. What I can say to people out there is, if you feel something, do something. Again, I said earlier that I never felt mine. I didn't know that I had AFib until I was told that I did. Since that time, I'm very aware of it. If I think that I feel something different, but the reason that is because of Dr. Ramirez explaining everything to me and saying, if you go back into AFib, this is what you're going to feel like. I've never had that feeling, and things have been going great. But what I want to tell people is it doesn't matter if you live in the rural area, it doesn't matter if you live in a metropolitan area. The fact of the matter is people have the same medical issues regardless of where you live. So being able to have someone for those rural areas in the western part of Kansas where we were, and to be able to go to a specialist like Dr. Ramirez and not have to travel. Some of those areas could be 7-8 hours if in fact he didn't come to Great Bend. So don't let that be the deciding factor of whether you get treatment or not. The fact is, it is available through the graciousness of University of Kansas and Dr. Ramirez and his staff for coming out. So that's my biggest, takeaway from this and message I'd like to get out. If you feel something, do something, because the fact is, you don't know what it is. You may not know what's going on, but don't just think like I did, it'll go away and fix itself, because there's a lot of times it won't.
Lisa, do you have anything to add?
Well, I just think this, interview is perfect, because, the more people you can reach and let them know what is out there and the doctor's professionalism, and that's what they need to know so they can get help.
Jody, we have viewers from all over the state, all over the country who watch this program, really. We actually have some international viewers as well. What would be your message about the Care Collaborative for healthcare providers and people watching from smaller communities?
I would say thank you to those providers like Clara Barton, who identified that early on and got you to the right care, for really working to provide that same high quality care, regardless of whether you live in a rural community or an urban community. That's something every patient deserves. And the fact that these providers are willing to work with us and partner with us in order to do that is greatly appreciated. And we've trained more than 4,000 providers in our first 10 years, and we're just getting started. But we really appreciate the fact and thank them for being willing to join in this effort.
Dr. Ramirez, you're so busy. You've got to go see patients soon, but I love that we were able to start off this morning for you as almost like a big love letter to you. What a compliment. What's your response?
Well, I think first of all, Glenn and Lisa, this is why I do this. I think, we don't go through all this training because at this end, I'm going to, be writing all these notes, going to be doing all these things that comes with it. But the reason we do it is for you. I think you guys are, everyone in their own, in their own world, and everyone is special in a way. And, you've come into my life and we've been able to kind of travel through this journey, and, you're doing better. I'm getting you back to doing the things you want to do, building the confidence that you need to be able to continue to do those things. And that's really what matters, and I think so, as much pleasure as, I get a lot of, definitely a lot of joy from, hearing what you have to say. And I really thank you, because this is what, this is what it's all about. It's what keeps me continuing to do what I do and continue to approach things the way that I do it. And, this matters a lot to me. So I'm very thankful to you and Lisa for, all those wonderful comments. Jody, thank you for, setting up programs like this. These are extremely important. And, I think that there's so many opportunities for us to improve, health in those areas. And you're doing it, and you're doing that, and you're connecting, these patients with the needed specialties that they need. And that's unbelievable and incredible. And so overall, just, very, very thankful that I'm in this opportunity to be able to provide, and that I have the resources to do it, and that I have, that I have the gifts to do it too. Right. So.
Dr. Ramirez, we have one more thing for you. We love sharing the incredible work that you do as a doctor here at the health system across the state. But our viewers might be wondering, what does Dr. Ramirez do outside of the hospital walls?
Now for a secret look into the guardians of healthcare at the University of Kansas Health System, let's go behind the mask.
All right, Dr. Ramirez, we're going behind the mask, and you are on dad duty. That's a full-time job in itself. Tell us who we're looking at.
Yeah, so this is definitely dad duty. So this is my oldest here on the left. That's Gabby. So she's my 10-year-old. Kind of my, if I go over from next to her is Pilar. She's the one that's, she keeps me busy. She's my handful. Mm-hmm. And then Eddie here, he's my little athlete here. So he's wants to get into everything called sports. And, believe it or not, I think he's just a real big football fan, and that makes me happy. And nice. The little guy here in the striped little jumpsuit here, that is Nico. So Nico is just, just starting to talk, and, has a lot to say. Nobody understands what he's saying, but he's got a lot to say. But
got a lot to say.
It's a lot of fun.
Maybe in 20 years we'll be interviewing all of them as doctors traveling the state. Finally today, we want to tell our viewers about a golf tournament with heart. Golfology for cardiology. Yes, it's spelled F-O-R-E. Players enjoyed a beautiful day at Shadow Glen Golf Club for the tournament. The husband and wife team of Larry and Jolinda Vega started this tournament 16 years ago because Larry is a grateful patient of the health system. The money raised each year plays a critical role in meeting the needs of our cardiac patients here at the health system.
When people go through a life-changing event like a heart attack or a bypass surgery or a valve replacement, trying to know how to get back into doing their life and how to exercise again, how to try to prevent it from ever happening again is a really stressful and challenging thing for people. And so cardiac rehab allows people to really get experience seeing that they can recover from this.
That's Dr. Brian Wyford. He's the medical director of cardiac rehab, and he says this tournament allows the health system to also expand its services through equipment, other locations, and virtual options for patients. Golfology for Cardiology has raised at least $115,000 and counting for this year alone. I want to give a huge thank you to all of our guests, Glen, Lisa, Jody, Dr. Ramirez. Thank you for taking the time to join us, and thank you to our viewers for joining the conversation. Coming up next week on All Things Heart, when she was diagnosed with breast cancer, she didn't slow down, she got moving. And her doctors say that had everything to do with protecting her heart during her treatments. That's next Thursday at 8 a.m.
Coming up tomorrow on the Morning Medical Update. They've been called game changers, miracle drugs, the answer to weight loss. But what are GLP-1 drugs really doing inside your body? I'm Jessica Lovell on the next Morning Medical Update. Don't let the side effects surprise you. Join us for a deep dive into their effects on your gut, heart, brain, and more. Friday at 8.